kicking us off here is Shobha Sadasivaiah. Shobha is a clinical informaticist at the Office of Health Informatics, as well as the Director of Patient-Facing Technology at the San Francisco Department of Public Health. And at the University of California, San Francisco, she's a clinical assistant professor of medicine. So Shobha, can you lead us off here?
Thanks, Steve, for your kind introduction, and thanks to the OpenNotes group for having me participate in this presentation. The goal for this section of it was to kind of figure out what the controversies surround sharing open notes and mental health might be. And so when I was sort of thinking about how to put this together, I thought, well, let's just see what people are actually saying. So I kind of looked at the lay press articles that were written about the topic and just put some comments together about what folks were actually saying, and we'll have a dialogue with Steve about that. So one of the main themes that I saw come about was that open notes causes harm. This is a quote here. Sounds like an interesting concept. Maybe it's a little helpful in some cases. Therapists might self-censure if they fear that the patient were to read insights from their therapist. It could cause the client to withdraw, become more closed up during discussions, become angry, feel let down, or worse, want to exact violence on the therapist. So Steve,
next slide.
Comments on?
Well, I think that's a very typical comment that we were receiving, and in fact, actually, when, as you're highlighting, when the press came out about this, all the various newspapers, there's about 90% negative, the comments in most of the papers about that this was really going to be ruining therapy in all kinds of ways. It was very adverse to patient well-being.
And have you seen instances of sharing notes where that resulted in violence on the therapist?
We have not seen anything so far across the country. Nothing so far, and we have many, many centers that have it open now, and many for a long, long time. Great.
So the next theme, providers will change how they write their notes, and important information from the documentation will be lost. So this quote from Dagwood, can't say I approve therapists will be writing, quote, to the client now, which may not be the content best suited to best treatment. Psychotherapy is a demanding and sophisticated art with its own language and understandings. This project disrespects it and may not be the best for clients. Continuing on, talks about robbing the doctor of her need to codify clinical material. So Steve, would you say that in your experience personally or those in your group are people drastically changing diagnoses or the way they're writing their notes?
So initially, when we embarked on this 5 years ago, we actually thought that this would be exactly what people would do. They would, sometimes the language was, they would dumb down their notes. They would modify diagnoses to put down the most benign but perhaps defensible as opposed to the ones that might be the most pejorative, and that they would write in a language that would safeguard themselves. So rather than, it's almost like thinking about defensive medicine, we'd have defensive psychiatry or defensive mental health. We have, in fact, actually not seen that at all. When I started with our group, we had a work group that was going to be doing putting together the thesaurus for languaging, relanguaging what we would put in the chart, and that group disbanded after several months because they found it was totally unnecessary. And the fears that you're highlighting there, Shobha, about speaking freely, every client when they first start out in any therapy, the question is always, is my therapist going to understand me? And that's a part of the therapy itself. And our view is that OpenNotes has actually been a vehicle for helping to have a better dialogue with patients to make sure we're better understanding them in some ways. And I think in some ways it's created better partnerships, which I'll get into a little bit later with some of the research that we have about this as well for the last 5 years. So that's it.
Another theme I saw is it will change the therapeutic relationship between the provider and the patient. So there were several on this theme talking about transference, as you can see, and sort of the relationship between the therapist and the patient being dramatically different for the worse.
So what I would say about that, typically what we have found with the feedback we've gotten from patients both here at Beth Israel Deaconess Medical Center, but also around the country and in Canada, is that patients oftentimes what they look for is whether there's concordance between what we say in the office and what we write in our notes. And what patients have routinely described now is that when they see the concordance between what is said in the office and written in the note, they're greatly relieved, and we believe it's strengthening. We haven't researched this fully, but we believe it's strengthening the alliance a great deal and solidifying the transference in another way, or it presents an opportunity to clarify misunderstandings as well. There's a lot of folks when they enter therapy are very ambivalent about being there, and a lot of that can get played out in a variety of ways. And so this is one way, I think, to improve the dialogue with patients directly and to be more transparent and accountable so that they don't feel like we're hiding things from them, which is oftentimes what they actually worry about. So I think, in fact, actually it's really strengthened the relationship, and that's what we're finding in the VA with Steve Dobsha's group. They've been doing some terrific work to document this as well in terms of strengthening alliances.
And not at all like an adult report card, as the quote.
That's right.
The next theme, sharing notes will create double charting. So I did see a lot of comments about this particular topic. Here are a few highlighted here that people will make sort of a patient-centered chart and then a, quote, real chart with double sets of notes and or sugarcoating serious concerns.
So how I would address that is there's 17 major kinds of therapies, and where this probably fits the worry or the concern of that writer is probably mostly around psychodynamically oriented psychotherapy. And I know most therapists, we keep separate side notes, process notes, oftentimes of what we're kind of experiencing. We use our countertransference in a very direct way to tap into what's going on for the patient. And that doesn't really change. And we don't think, in fact, actually, we haven't seen that it has changed at all in terms of it just has not changed at all. So,
and you don't see anyone writing two sets of notes in your experience?
No, not unless they usually did before. The only change I would say in that regard is that there are a lot of therapists that write notes to kind of remind themselves of what happened in the session, and it's kind of a tickler for themselves. And some therapists have found that they don't really need to do that, and they may keep a side note but it's more about reminding. They were doing that as a convenience to themselves to have it in one place. So few folks have described that they simply do that, but it hasn't changed the logistics of the workload and the time intensity of any of the note writing at all.
Great. The next theme, and I will say this is probably not specific to mental health. I've gotten a lot of questions about this as well, but that OpenNotes is not appropriate for certain sensitive conditions. So in this particular comment, they talk about people with anger management issues, psychotic features, and personality disorders, and that this could be harmful for them. Do you have a practice or in your group about not sharing notes with any particular patient based on their diagnosis?
So yes and no. So I think the fears that you're describing, particularly most groups are worried about very paranoid or psychotic patients who might be prone to anger issues, whether we would do something with that. And we have not actually found that. And now I will say when we started this 5 years ago here, we did this for all the staff here at Beth Israel, one thing that was important was that I also work in bioethics, and my notes when I write a bioethics notes, which is oftentimes a very controversial, oftentimes legally charged situation, we as a policy, we make our notes directly available to the patient, to the family, to anybody involved in the consult itself. And we found that we cut down on calls to our legal department when we started doing this by better than 50%. And during the first 2 years that we embarked upon that service 20 years ago. And so we found that the transparency was really remarkably helpful, particularly in volatile situations. And myself and one other colleague, one of my other social work staff, the two of us embarked about close to 30 years ago when managed care started coming on the scene with opening up all of our notes when patients were coming into the office and offering to let them have that. I was worried that all my paranoid patients would leave, and we in fact found that that was not so. So we in fact found that they were very much reassured that they could in fact read their note at any time and keep going. So that was really reassuring, and that's been what we found across the board, is that it's been actually very helpful. The one population I would say where there's some worry about this is patients who are victims of domestic violence. But that's always been an issue, that, for instance, if I see a patient where the perpetrator of the violence might be the health insurer, the subscriber, just the fact of my generating a bill for that may in fact actually increase the danger to that person if there's that person says, oh my gosh, you're talking about me in a therapy, you're seeing somebody. So that's always been one of the reasons why most programs around the country, almost all programs, are free and do not use insurance. So we kind of have culled that out as a little bit of a safety area, just because we don't want perpetrators reading the notes of their victim in that way. But really what we've done is just talk with victims if they have open notes.
Shobha, while we're waiting for Steve to come back on, maybe we can just go through the rest of the concerns and let him respond at the end.
Sure, that sounds good.
Great.
So the next one that came up, is this just an academic experiment? Is this only something that could be executed at medical centers? Is this just a research question? Next slide. And the comment around this was is this academics competing to innovate and generate publicity have gone on a highly questionable route. And this is one of the comments from the article. Mental health is different than physical health. I think this comes up a lot with a lot of OpenNotes implementations. This particular person highlights reading a note by a therapist is not the same as reading a note about one's broken arm or appendectomy. The result will likely be notes that become more feedback for clients rather than candid thoughts meant for therapist reference. Is an in-person communication preferable? And this I saw as well come up in various settings, that it is better to have real-time communication and synchronous communication instead of asynchronous communication. Next slide. And this comment here sort of highlights this idea, a poor idea in most cases because notes do not convey meaning in the way that in-person communication can. The nonverbal information and the context are stripped away, and it continues on.
Thanks. I think we have Steve back.
Yeah, sorry about that, folks.
No.
So, Shobha, it's an interesting quote that you have there, because it's it is that kind of thing where there are patients where in fact actually it's not always great for them to read the notes by themselves. And the analogy we use is that it's like prescribing a medicine. You have benefits for most. It could have side effects for some, and our job as clinicians is to figure out who might have side effects for. So I had one patient, for instance, that was reading her notes after, this is in a group therapy patient, would read her notes and then she would decompensate afterwards. She had no one to process it with, and she really got more isolated, got a little bit more psychotic at times, and she really struggled. And the groups, took her on about that and basically said to her, don't read the notes until you're just about to go to your individual therapist session or to the group, so you have a place to process it. And it turns out then she started bringing her notes into the group, and she was distorting almost everything that was there. So that was an example, for instance, where the group actually worked with her, and that could have been done in individual therapy too, to say that. So there are times when, in fact, you have to think about whether the note will be beneficial to the patient or not, and that's something I think can be negotiated. This is not a tool for everybody. It's one more tool in our bag of tricks, if you will, within all the various kind of therapeutic interventions that we might employ with different patients. So that's partly where I think about it, is that to adjust it, it isn't just that this is for every single person always the best thing. So.
Thanks, Steve. That was the last one, but we looked at a couple while you were gone, and that was, is this just an academic experiment? And isn't mental health different from physical health?
Oh, good question. So mental health, I mean, it is different and yet it's overlapping. Certainly we have parity diagnoses, where you have what we think of as endogenous conditions that are, part of the body and part of the chemistry of the body. So we have that. But what we've learned in a lot of ways, just like in the physical health realm, is that the more information you can give to a patient, the better armed they are to kind of be able to deal with it. And if we think about it on the mental health side, this is an example I oftentimes use. Patients with borderline personality disorder, we oftentimes recommend for them to utilize dialectical behavioral therapy, and DBT is predicated partly on the patient knowing as much as possible about their very diagnosis, that they learn about it, they learn strategies for kind of dealing with it, for thinking about it, for recognizing when they're in that black, white, all, nothing kind of a mode in that way. And so that's part of the notion here is just like in the physical health, I would say that we really have an obligation to be very transparent and accountable to patients in both realms. All right, Shobha, thank you for your part.
Thank you.
So I will take over for my next part, and a lot of my slides I'm going to go over some of them I'm going to gloss over because we've covered that a little bit. So my role basically at Beth Israel is that I oversee all the behavioral health, mental health practices, both inpatient and outpatient in that way. I have no conflicts to report. Next slide, Amanda. And what I'm going to be doing is sharing impressions from 5 years of experience with fully opened behavioral health, mental health notes, plus some glimpses around the U.S. and Canada. And thinking about what I just mentioned, notes kind of thinking about it as almost like a different variation of narrative therapy for behavioral health and mental health, mental illness. And then talking about pros and cons of all of this. So our three basic questions were, just like in the medical side, would OpenNotes help patients become more engaged in their care? Would OpenNotes be the straw that breaks the therapist's back? And after a year, would patients and therapists want to continue? And we always start with what is best for the patient, of course. So we think about this as moving towards patient-centered care and away from provider-centric care. So we started basically in the psychopharm part of psychiatry at Beth Israel in March of 2014, and then in social work in April of that year. And we did kind of an opt-in psychiatry. It was 10 patients apiece, and then ramping up after that to being fully open. And in the social work department, we used staff could either ramp up similarly, choose patients they wanted to do selectively that they felt comfortable with, or they could opt out altogether, or they could just fully open up altogether. So that was how we started with all of that. We had 15 psychiatrists participating in psychiatry and 29 social workers who agreed to the pilot. There were 5 that declined, so we really had 24 to start, and we did not include our trainees at that time or pediatric therapists. Currently, we have better than 4,000 patients who are in open therapy notes. And out of that 24, by the way, almost all of them are fully open, and just about every one of them is now just fully open. And all of our staff now, that when we have new staff added over the last 5 years, they have just automatically been opened up as just part of the way we practice. Just like Shobha said, there would be increased work burden and misunderstanding. There was a lot of concern about that. There was concern about the relanguaging and whether patients would get angry about that. Severe mental illness, whether they would flee, and we've talked about that in the paranoid patients. And then the domestic violence and safety exclusions. And then I'll make note, just as a little thing here, obsessive patients. When I mentioned before about the benefits and pros and cons, there's a patient that I always love this quote: "I've spent my whole life learning not to double think. When I go to my mechanic, I don't want to look under the hood. Same here." So for some patients, they actually choose not to want to look at notes, and that's fine. So that's one aspect of it. I had a paranoid patient that did not want to look at his notes, and it took him for 2.5 years. His notes were open, but he never looked at a note till 2.5 years later. For me, it was a marker of his health that he could finally look at that, and every once in a while he looks at his notes now, and he finds them helpful to see that what I write is similar to what I say in the session. We did start with a work group, as I mentioned before, that we eliminated very quickly. We did have FAQs that we developed for the staff, including the front desk as well as patients, and all of that is on the OpenNotes website. If anybody wants to plagiarize any of it, you're welcome to utilize that. Next slide. All the publicity we had was that we were ruining therapy, and this was all the things that Shobha pointed out before. Next. What we have found with the research is that better than 90% of patients agree that opening up therapy is a good idea, and 85% want to continue having notes available. Now, what about the other 15%? With them, it was more immaterial. It wasn't that they thought it was a bad idea and wanted to have it turned off. They just didn't matter to them one way or another. Okay? And there were very few patients that said they felt more judged, worried, or offended. And yet, if you look at the data there that I have down below, it's 15, 10, and 5%. That's significant, but I think that correlates with patients who are struggling when they first enter therapy and may have worries about whether they're being understood or not. And that's all part of the therapeutic process of developing an alliance with someone. Next slide. The adverse effects that we had, oftentimes we found that it was really more about concerns about privacy. Who else gets to see my note in the system? So if you look at the systems that we mostly have, like in our system, our mental health notes are embedded and directly a part of the medical chart itself. So when a physician or nurse writes their note, or a physical therapist, my note is right in among all of them. So that was something where many patients said they would rather have limited who gets to see the note to people that they view as central to their care. But that's a hard thing to do, particularly in an academic institution. So anyway. And then the other thing that was striking is that patients never mentioned to their therapist about having read their notes, and the therapist never asked. And I think that really correlates with our training as therapists. Oftentimes we wait for patients to bring up things, and yet in this instance, patients were waiting for us to bring it up because we were the initiators of that. So it was striking that we found that there was it was not being talked about as much in therapy as we expected it to be. We also found that the reading rate drops off for patients that are more of our ongoing patients, and part of that is because there's a lot of redundancy in what we say and what we write. Next. In all practices, our own as well as across the country or Canada or anywhere really, everyone has concerns about some nightmare patient. And what I would really say is that, in fact, actually, there's an index for contagion among staff where they think about the nightmare patient that they've heard about in the practice, and everyone kind of highlights that one person. And maybe that is a person where it might not be beneficial. My own experience, and this is anecdotal, we have not researched this, is that for some of these patients, I think we've been able to contain them more by being able to say to them, please look at your note and look at what we've talked about. And particularly with those patients who have trouble between sessions hanging on to things that we've talked about. Those ones really, I think, benefit a lot from all of this. So, and these are labor-intensive patients. They're going to be labor-intensive no matter what you do, I think, too. In our studies, we have better than 50% felt more in control, felt better about their self-care. Better than 40% felt they were able to remember what they're working on in therapy better. And I will tell you from my own practice, I have a lot of patients that print out their notes and put them on the refrigerator or someplace as a reminder of what they want to do. And 40% felt that they were more engaged in their therapy. Again, that may seem low, but to folks watching this, I would say that what we're really talking about is that those other patients already felt engaged. So it didn't make a difference one way or another. But 50% felt they were better able to trust their therapist. Most described having good trust already, though. 80% want to continue. 60% said that it would affect their future choice of a therapist if they were choosing in a community between therapists that are in OpenNotes and those that are not. 60% said they would choose with the person that is in OpenNotes. And not one therapist or patient asked to stop, and almost all have since joined now, as I mentioned before. And my staff, they all had the option to not join too. So we now have 51 networks with mental behavioral health notes opened up. 19 responded to a recent survey that we put out, and the question about distress since opening up, and this is from 2 of them. Quote, we call the pilot the big yawn. We received no concerns or complaints from patients, and this is a practice, this is a network that is 4 years into opening up mental health notes. The next practice is another one for 3 years it's been open. Concerns are unfounded, and patient complaints are very rare. If concern arose, the patients discuss with their clinician. Sometimes the patient had a good point of view. So again, sometimes it's a missed opportunity if we don't have that opportunity to do something with it. The other thing I would say from lessons learned about all this is I oftentimes refer to the 70-30 rule, that when you go to a physician or a nurse for a well visit, you generally remember about 70% of what you're told in the session. That still means you're missing about 30%, and a note can refresh folks and be very beneficial. If you are delivering bad news or uncomfortable news or difficult diagnoses or what have you, then it's flipped. It's a 30-70 rule, that only 30% is retained at best. That's true in the medical side, and I believe it's also true particularly in the mental health side, where there's a lot of anxiety or a lot of depression that can really block the ability of the patient to really hear what's going on. And so my sense is that the notes, in fact, really enhance the therapy itself. The other thing I would encourage folks to think about is that when we opened up our notes on the medical side first, and then with a medical specialist, and then we joined at the very end of the medical specialist on the mental health side, I think the fear was that our patients wouldn't be able to handle it, and I think that in fact actually falsely contributes to stigmatizing our patients even more so, because what we found is they can in fact handle it, and it was more about the concerns that we clinicians had. It was really our anxiety, I think, in that way. So I would encourage folks to think about mainstreaming and opening up mental health notes along with their medical notes, because I think, in fact, it decreases the stigma. And in mental health, we oftentimes think about we're treating disorders of control, and OpenNotes helps our patients to feel more in control and more engaged. I mentioned the professional fears. People don't want to look foolish or incompetent. And then we have issues in all systems about how active or passive utilizers are of this of OpenNotes in terms of whether it is a tool in their bag to pull out or not. So, next question. Okay, now we're going to shift over to Stacey Whiteman. And Stacey is one of our patient family advisors at Beth Israel. And Stacey has graciously allowed us to look at a mental health note of hers that she was willing to share. We've de-identified some of the information in there, but maybe we could just go through that real quickly. So we have down here, this is the note overall. You can see this is just, Stacey wanted to have you see what a note looks like, and it's different. A lot of folks think it's the same as a visit summary, and it's not. This is a note, and I've just kind of highlighted some words in red that basically kind of go through a little bit about this is from the social work therapist, and then there's the a little bit about the problems and the issues being worked on. Stacey is someone who was diagnosed a few years ago with MS. She'll be talking about that. And so this goes through a little of what they're working on, and then gets into the mental status and the clinical assessment, and then the diagnosis. So we pulled some of that again off, but it would be the typical ICD coding, and then the recommendations going forward in that way. And Stacey, do you want to open up for yourself?
Sure. My love affair with OpenNotes began right after my diagnosis with progressive MS. That diagnosis came out of nowhere. I used to be a high-functioning executive assistant, and then one day it all went away. I could no longer function. My life became very chaotic. My brain was a million different pieces. I couldn't understand my illness because I was so stressed out because my brain was a mess. I was neuropsych tested, and it came out of that I needed to see a therapist in order for me to manage my care. And in order for me to manage my care, I needed to become less stressed and less full of anxiety. Now, I also had a history of depression. So I met my therapist, and the first thing she said to me was, how are you going to feel about our therapy sessions going into OpenNotes? And I said, I'm going to love it. And she said, really, why? And I said, because I'm not going to remember anything that comes out of this session. I have a hard time processing things now. My cognitive functioning decreased so rapidly that I couldn't make heads or tails out of anything. My kids went to go live with their dad. I couldn't function on a daily basis. Tasks became unattainable to me. So during my sessions with my therapist, we talked about a lot of different things, and she had a knack of putting my different words into making sense for me. And then I would go home and I would read my OpenNotes at my leisure. I could understand them better because I would continue to reread them. And we always had an assessment. We always had a follow-up. I always had homework. I always had things that I needed to do in managing my care until the next appointment. And that was a huge tool for me. And eventually, over time, I could understand my illness better. I had no idea what MS meant. I had no idea what was out there. I didn't want to know what was out there until I understood my illness better. I didn't know if parts of it was my depression or if parts of it was part of my MS, and my therapist had a way of helping me decipher that. I also have a psychopharmacologist who regulates my medicine, and OpenNotes allowed me to be able to take my sessions and PDF them and send them to him, and he would regulate my medicine based on my sessions. If I was experiencing a lot of anxiety, then my therapist would say, you need to get this over to him so that he could regulate my medicine. Not everything was about my MS. Not every symptom was about my MS, and my therapist would have a great way of helping me decipher that. Because it was an invisible illness, and I'm sure all of you are looking at me saying, she's articulate, she looks good, there's no way she has MS, but what people don't realize is I'm fighting a battle inside myself. And I hide it well, I hid it well from my kids, and I would go into my sessions and say, this is so frustrating, I'm in so much pain and people don't understand it, and how do I cope with this? How do I get past it? How do I make people understand my illness without having them feel bad for me? I don't want people to feel sorry for me. I just want them to understand that I can't process things. I want people to understand that sometimes I just don't feel like going with my family today without them being upset with me. And so there were a lot of different dynamics associated with having progressive MS. And I always said that I'm the person whose life changed in a split second. I went from being a high-functioning executive assistant to being somebody that had those skills no longer existed in me. And therapy continues my therapy sessions. Every week I read my therapy notes. Every week I find something different in my therapy notes. And my open notes are an extension of who I was in my previous life. And I rely on them very heavily to manage my care. And, you know, I have an MS doctor. He has open notes, but he is just that. He's my MS doctor. He tells me when to go for my infusions. I do a checkup. I read my notes. Okay, fine. My therapy sessions, I relive my appointment all the time, and it just keeps my therapy going. And when I was preparing for this webinar, I was looking back the past 4 or 5 years on how far I've come with my therapy and understanding my care and managing my care better. And I have really come a long way in managing my care. I'm not stressed. I can read blogs now. I can understand my illness. I'm not afraid to see what's out there relating to my MS, whereas at first I was, because I wasn't prepared for it. And OpenNotes has become a huge part of my therapy and a huge part in managing my progressive MS. And without it, I have no idea where I would have been today. So.
Great. Thank you very much, Stacey, for sharing your experience and your note. You've been an amazingly courageous person throughout this journey. Okay, and now we're going to be switching over to Emily Gibson. Emily is the medical director and family physician at Western Washington University Student Health Center. So Emily, could you take it away?
Yeah, I'm really inspired by what Stacey just said. And it's really what fuels my staff's interest in helping college students who are really very new and naive to managing their own health care, to have them just simply have an expectation that their notes will be shared with them. So we're about 4 years into our OpenNotes system. I'm a family doctor and director of the Student Health Center here, 16,000 students. But because of the demand everywhere for mental health care in college students, about a third of our students have a mental health diagnosis, and majority of those are actually in active treatment, either medication or therapy or both. We have to do a lot of mental health here in our primary care clinic. So the medical chart here is completely open to the student with a few limitations that I'll talk about. I'm now doing behavioral health full-time because of the demand for that kind of care, and that's primarily medication management. We are not doing therapy here in the health center. We have a counseling center that does some limited brief therapy with social workers and psychologists, but most of the students who need ongoing therapy are referred off campus. So we're not talking about therapy notes. We are talking about mental health, behavioral health, assessments, evaluations, including psychiatric providers in our clinic. So that's what students are seeing. And they're seeing these notes just like they see their medical visits. And so they don't see this as being somehow different or unique or special because they just simply have access to any of their notes. We have the option with our current EMR to either give them full access to the full note or a partial note. And we let the student know that they're either able to view a full note or a partial note. And I have 4 psychiatric providers who work here coming in from private practice. They spend a day or 2 a week here, and the vast majority of those providers feel more comfortable with a limited note. Now, a partial or limited note would include the diagnoses, basically the axes, and the treatment plan. And if the student actually wants to see their full note, they can request that, and we make arrangements for them to be able to see their full note. So my notes, since I'm a primary care physician and I'm approaching my behavioral health assessments pretty much like a primary care physician would, I share the whole note. It's very unusual that I would feel like a student should not see their full note. We make sure that students are reminded that they have their notes available to them, and we track this, and 90% of our students do read their note within a 2-week period. If they haven't read it after a week, we send out an email that reminds them, hey, you've got a note to review. And then if they haven't reviewed that note after 2 weeks, we do a text or a call just to remind them that they have a note to review. This is pretty critical for us because just in terms of being able to do in-clinic follow-up, we just don't have the space for all the students that we need to take care of. And so a lot of our care and check-ins are by patient portal visit. So we're doing messaging, and we really want the student to understand the treatment plan through the portal itself. So that's how a lot of our care is delivered, is actually through this messaging. So students, the patients love having the access. They rarely have questions about what they see in the notes. They sometimes have clarification, but otherwise this has been a very successful thing for almost 4 years now, and we will continue it. And in the future, we're going to be integrating with our counseling center, where we're going to be sharing an electronic medical record system. And I'm hoping that my colleagues over at the Counseling Center will be willing to allow some access to their therapy notes, primarily because these are crisis notes and they are brief therapy. They're not long-term therapy, and so I think they're probably going to be more amenable. But at this point, we just are not on the same system, so we can't do this yet with the actual therapist. So that's our experience here.
Great. Thank you, Emily, very much. And now we can open up the dialogue to any questions and comments that folks would like to make.
Yes, thank you to all the presenters. I'm unmuting the presenters, and also Deb and Liz have been monitoring the chat box, and so they are going to be posing all the questions that have come through.
Sure. So this is Liz Salmi with OpenNotes. I've been monitoring the chat box along with Deb. And so the first question I have is from Kevin, and it says, and it was during Steve's presentation, but it says, could you clarify or specify exactly what documents are being shared with patients? For example, progress notes, psychotherapy notes, medication lists, discharge plans, etc.
Great question, and I should have been clearer. Everything we can see, the patient can see. So they can see their medications, their labs, their progress notes, their initial evaluation. There's nothing that I or any other clinician, anything we see, they see. There's one area where we actually, labs are, there's a lag time often between when if a lab is drawn, say on somebody that's going through cancer workup, those labs, there's usually a delay of like 3 days, business days, before the patient can see it. That allows the clinician to see it first, to be able to work up a game plan, to call the patient, et cetera. So a lot of systems have set it up where there's a little bit of a lag time between when the provider sees it and when the patient sees it. But in our system, we have the lags on the lab, but everything else, as soon as I sign a note, that note, the patient gets a prompt that says to them, you have a note to be read if you care to. And when they're returning for a visit, we have a prompt that goes out several weeks in advance of the next upcoming visit that says, you have an upcoming visit. Would you like to see your note from your last session to refresh yourself? So that's what we do, but it's all fully open, everything in the record.
Steve, this is Deb. So another question that came through was about pediatric mental health notes. I did mention in the chat that we will have another webinar at some point just about pediatric and adolescent notes, which is a whole area of discussion in itself. But if you want to touch on the mental health piece of that.
Sure, glad to. Yeah, that's been a trickier area, and in our hospital, in my end, we're only.
Well, while Steve is getting back online, I'll mention we had a number of amazing comments thanking Stacey for her presentation. And Catherine says, amazing work, Stacey. Your persistence and resilience are so apparent. It's wonderful to hear how OpenNotes has helped you in this journey. And then Shobha has also said the same thing. That was an inspiring message. So on behalf of all of us, thank you so much, Stacey, for sharing your story.
So I don't know what you heard or what you didn't hear, but about this. But Children's Hospital and a number of places around the country have opened up both on the medical pediatric side and on the mental health side. Anyway, they have done it in a way where it really tailors it towards the age. Most places do it so that someone that's over 14 or over 16, they have different levels of what they can or cannot see in terms of that. Because there's always the issue about how much can the parent see in that situation, or the surrogate decision maker. So that's been a tricky issue. Most of them are working it out and finding that it's working pretty well to give the adolescents in particular a lot more control over their notes, and that there's a lot more adherence and follow-up with their care, both on the medical and on the mental health side. But a lot of the data on that is a little bit preliminary too. It's a good question that Kevin asked.
So we got this question from Stephanie. I'm just kind of going out of order. I think it's important to bring up Stephanie's question. Maybe I should have done it first, but Stephanie asked, can you speak on how OpenNotes works? This is an actual documentation program, ? I work for a geriatric IOP at a rural hospital, and we are on paper charts and use electronic Word documents. Do patients have to have internet access at home to view the notes? Most of my patients do not have internet access.
So, Steve here, I'll try to tackle that. So I think that's a tricky question, because you're right. All of these systems are contingent upon internet access and a secure platform. So patients, don't just have, they have to log in, and there has to be all kinds of security and protections, to the login process, so that we can minimize any ability to have our systems hacked. And so that does make it a little trickier for patients that are not on the computer. That's been problematic in some regard. I will say that we have some studies out of OpenNotes that show that, in fact, actually a lot of our populations that are blue-collar populations that were less computer savvy have still loved having OpenNotes. because sometimes it's another family member that's very savvy, and they can pull up the note. That person can pull up the note for them, and they can look at it together, or they can explain things. And a lot of times when people come home and they don't understand something that goes on, I think of my own mother-in-law. When she was alive, every time she came back from a physician visit, if my wife asked her how did things go, she'd always say everything was fine, and we'd ask if any changes. No, and then but if you looked at her notes, she might have hypertension. She's on a new medication. There was different changes at different points, and that's where, in fact, sometimes other care providers and caregivers can actually be very important for them to be able to see the note if the patient allows the access to it. But the paper notes is really a problem in terms of how do you do that? And before we opened up our notes online, I used to provide paper copies of the notes. I would print out my copy of the note if the patient requested it. But in our system, actually at Beth Israel, we've been on the electronic medical record since the mid-1980s, is the very first electronic medical record in the world. So when we put on mental health notes online in 1991 was when we started there with that. So it's a bit more experience. It's tougher in some of the other areas that you're talking about, where we have to think about ways to kind of get notes available to patients.
Steve, a couple of questions came through about making corrections. So Shobha asked if you can talk about BI's process for chart correction if patients want to change their records. And then Jane, in a follow-up, said, has there been an increase in patient amendment requests?
So very good questions on both. There have been some patients that have asked about amendments or changes, and we once we have signed a note legally, we cannot change that note. It's not amendable in that way. But I will say that what I can do is you can add an amendment. Most electronic systems allow for an amendment to the note itself. So it's a legal document that's required. Once I sign it, it's done. But I can give you an example of a patient of mine who I put down in a note about how her son had completed his suicide, and I misidentified the way that he had done that. And that was very important for her, the way that he had done it. And so I amended my note to correct that. And that was, she was, I think, so grateful that I would do that rather than looking at the note and kind of stewing about it, that I could add on an addendum to that. And that's kind of the way we deal with that a little bit, is that, we can add an addendum or a correction. I went to see a physician for my own health not too long ago, a specialist, and he wrote down that I had quit smoking 20 years ago. Now, I'm in my 60s, and 20 years ago is very different than, in fact, actually what I told him was I quit smoking when I was 20 years of age. So that's a very different thing. So he had to do a corrected note. So he wrote a new note that corrected that information in the chart and added an amendment, an addendum to the original note. That's the kind of thing we can do, but we can't really change the note itself, unfortunately.
Steve, we have a couple questions from Simon, who identified himself as an Army psychiatrist, and that they are looking at sharing notes in behavioral health. And Simon says he's interested in learning more about sharing behavioral health notes as it pertains to sexual assault, TerraSoft, forensics exams, as well as domestic violence, children, and any other resources around that.
Okay, that's a very interesting question, and I would say that for one thing, actually, the VA is one of our prime examples, because they've opened up their mental health notes both on the mental health side, both on the outpatient side and on the inpatient side. So they've done it there as well. So there may be a lot to learn there from, for Simon to learn from that experience. In terms of TerraSoft principles, and just for those that are listening in, that's kind of what we think of as the duty to protect or duty to warn principles that grew out of a California case, TerraSoft case back in the 70s. And TerraSoft has been kind of changed over the years, for the standards that we operate under, and it varies by jurisdiction. So here in Massachusetts, we use a clear and present danger standard. And generally what we've found is that when I've had patients, for instance, I do some forensic work as well, and the patients generally, I give them their notes, and I don't do it any differently. And when I have a patient who's very paranoid, for instance, or has had pretty unsettling thoughts, say homicidal thoughts or suicidal thoughts, I document. I have an obligation to document that, and I will usually document that what the patient has conveyed about their theory about what's going on, and then I usually say I have a different theory in my note. So, and oftentimes I will, with that population, I have tended to share the note with the patient before I print it out so they know what is coming. I mostly don't want to have them feel ambushed by something, and that's really what it amounts to. I know there are some staff in some of our systems who hold off on sharing notes until they're with the patient itself before they sign it. So there are some, if they're cautious about it, they'd rather do, it's like neuropsych testing. Many systems would rather have the patient come in for the appointment and really review all of the note and all that it means before they sign it. So some systems do, some clinicians do hold back on signing that because of the clinical reasons in that way.
Steve, Shobha had a question if you share mental health notes written by trainees such as psych residents.
Good question. When we initially embarked upon this, we did not share the trainees' notes. We now do. The exception in that is my social work trainees. So the psychiatry residents in training, they all share the notes. They are on board. The social work trainees, because they're operating under the license of someone, we've had some glitches where their notes are actually shared, but they're only shared once their supervisor has countersigned the note itself, because they're operating under that person's license. So that's when they are opened up. So they're opened up technically under the supervisor's license, but they really are the trainee's license, trainee's note in that way.
So that was all the questions in the chat box. It looks like we have a couple of minutes, Amanda, if anybody who wants any verbal questions that they want to bring up.
Oh, we just got one more question that popped in from Stephanie. Stephanie says, where does the responsibility lie with HIPAA if we are printing notes for patients to take home and read due to no access to internet, they leave our department and leave those printed notes in a public bathroom for anyone to see? Also, they are likely not being confidentially shredded.
Yeah, it's a good question. It's a very good question. And what I would say is that your responsibilities under HIPAA actually end once you give it to the patient themselves. But it's just like if for a staff person, you know, that if I go to the bathroom and I leave the notes in there, if I printed out something on a patient note, that's my responsibility, and it's a reportable incident under most systems of care because that's a kind of a preventable harm, if you will. And and it is a HIPAA violation if in fact it gets out and it really discloses something, private information that should be protected. Once you give this to the patient, I mean, the patient basically, any patient can print out anything that we've done at any time, and they can send it to their friends, they can send it to their family members, they can send it to somebody else for a second opinion. So it really becomes part of their domain to kind of protect it. Part of the informed consent process that we do with all of this is we try to make sure that patients really kind of weigh out the need to be careful about their notes in those ways. So that's what I would say.
Catherine asked if you're conducting any formal studies or evaluations now, and can you tell us when we can look forward to hearing more?
Sure, it's a good question again too. So we have two publications that should be coming out. We should get word on them. We thought we would have word on both of them this month, but we're waiting on that. So we have a couple of big studies that are coming out that should be out very, very shortly. And at any time, I should mention to everyone, on the OpenNotes website, you can get any of this. We have a mental health toolkit that you could look at any time if you want to see what that looks like and, you know, use that or think about the ways that it could be helpful to your practices. There is the literature is in there, so we keep that up current. So all the literature that's come out of the OpenNotes movement is on there. We try to keep that in process so that any of that is there for anybody to look at any time.
We're getting more and more questions, which is so great. And as you were talking, Steve, Catherine said, are you conducting any formal studies or evaluations right now? If yes, can you tell us when we could look forward to hearing more about them? And then you answered that as she was asking that. And then she says, thank you. A new question, though, is from Stephanie. Does anyone require a patient to sign an extra paper form before their mental health notes will be released?
I'm not, say that question again, Liz, I'm not sure.
And maybe, hopefully my inflection is right. does anyone require a patient to sign an extra paper form before their mental health notes will be released? So maybe are there extra protections to notify patients, FYI, you will now have access to your notes?
Yeah, there is not. I mean, I think what what that speaks to is that the worries that folks oftentimes have about practicing, making sure that we've covered all of our bases and we're practicing in a way that we kind of protect ourselves. And it's really a fear of litigation that I think arises from that. Our sense is that, in fact, actually, I mean, there's an informed consent process for all patients when they go enter our system. Our system the platform is called Patient Site, the web-based format where they can pull up their medical record, and the OpenNotes is simply the notes itself that's there. That we don't do any additional informed consent process of them, other than just simply going through about the need to make sure that when they walk away from their computer, they don't just leave it open, that somebody else could go in and look at their chart if they want to be careful. So we do, address that in those ways, but we don't have a separate consent in that regard.
Steve, there is a question here. It's probably pretty quick from Kathy. She says, you may have covered this earlier. My apologies if that is not the case. What do you recommend regarding substance abuse treatment notes? We are currently not opening access to these due to federal regulations and how we interpret those. Any thoughts? Yeah,
glad to. So I actually think that's I think that's a misinterpretation of the way HIPAA regulations are, and very common in the substance abuse realm. I don't think there's any reason to hold back notes in that way. And what I would say is, if we learn anything from the self-help programs, particularly Alcoholics Anonymous, which has been just amazingly successful for so many years, it's that the transparency and the openness. So you think about it, like the main criteria for recovery is honesty. And the ability to kind of look at oneself and can do self-examination and to be open to feedback from others. So when somebody has a concern, it's a cognitive behavioral approach usually that, in fact, actually, I think OpenNotes lends itself especially well for the substance using populations. And I know we have an opioid clinic here at our hospital, and they very much, their notes are open, and patients really feel that they benefit from it. It's like going to a meeting for them sometimes when they read their notes. So that's kind of what I would say. I think it's a concern that I hear about regularly from a lot of different practices, and I don't think that that's a correct interpretation of HIPAA regulations in that way. Thank you, and thank you, Shobha, Stacey, and Emily.
Thank you.
Thank you. Bye, everyone.
Bye.